Hello, everybody, everyone. Thanks to for the shoulder board number 6. This is a special shoulder board because we would like to know how to manage complex case of glenoid arthritis, particularly retroversion and superior tilt. And we are very lucky because we received Peter Habermeyer from Munich, Christian from Zurich, from Gerber, you know, Mark Frankle from Tampa, and Gilles from Lyon. And we are very lucky because they are the main experts regarding the difficult problem of the shoulder. And with Jean-David, we choose three cases. And we start with the first case of Jean-David. Thank you, Jean-David.
Thank you. So I'm going to share this this case. So it's a 35-year-old patient who's right hand dominant, who came for his left shoulder. He's a manual worker, and he has had shoulder pain for 3 years. And he says that it started after a motorcycle accident he had when he was in Colombia. And he's Colombian. And 1 week ago, 1 week before I saw him, he fell playing soccer, and he felt an increase in pain in his shoulder. And he had no passive external rotation. And so he was sent to me for posterior dislocation. And these were the x-rays when I saw him. And so, of course, it was not a posterior dislocation, but a severe posterior subluxation of the shoulder with osteoarthritis. We asked for contralateral radiographs, and here are the contralateral radiographs. And maybe, Christian, you want to comment on these radiographs, because I know that it's a subject that you worked a lot on.
Yes, I think it is, for us, the way we see that, you know, this is a classic case of very, very dysplastic acromion. And if you want, I will a little bit later show in a short presentation how the acromion is posterior restraint to posterior subluxation and dislocation, together with abnormal version. It is a combination of the two. And what we're seeing here on the right slide is an extremely short, very horizontal, and relatively high acromion. It's not extremely high because arthritis has led to the posterior subluxation, which also has put the head higher up, which is not necessarily associated with the rotator cuff tear. With extreme retroversion, the acromiohumeral distance can become very small, apparently, even though the cuff is still intact. So for us, this would be an absolute contraindication for an anatomical prosthesis, because there is a complete lack of posterior restraint by the acromion. But I may come back to that if you don't mind, if you're interested.
Yes.
And
what about the contralateral shoulder? Is it often bilateral? What you noticed, or?
Yes, this. If I'm still asked, yes. If you look at the Lamy view or at the near view, the head is subluxated posteriorly on this view, probably, although it's not exactly tangential. And the patient on this side has not yet had an injury and has probably another few years until he develops eccentric osteoarthritis. If we had a CT scan of the right shoulder, I would not be surprised if he had an static posterior subluxation.
Okay. Peter, Mark, do you want to comment on these x-rays? Anything to add? Or?
Yeah, in my own practice, I would ask for an axillary view. We don't see axillary view, but this would also show us that he has a posterior dislocation or static subluxation, and this can be shown easily on axillary views.
Okay. So the idea here was to have a very practical discussion. And so after 2 years, this patient of non-operative treatment, he finally was too painful to stay with non-operative treatment, and we decided to proceed to arthroplasty. I'm going to show you the CT, and the idea is to have the 4 speakers discuss on very practical discussions on how they're going to address the case, how they plan the day before surgery or the morning before, and how intraoperatively they reproduce the plan. So here is the CT scan. So first the axial views. So you can see that there is very severe posterior subluxation and retroversion of the glenoid. Then we can look at the coronal views. And then we also have the sagittal views and the soft tissue. And as Christian said, the rotator cuff is absolutely intact. So there was no problem of rotator cuff. And so first, maybe Gilles is going to show us how he would plan the case on his software. Yeah. So he's going to share his screen.
So thank you, Gilles. First of all, I would like to discuss about the diagnostic of this patient. I really believe that this patient had trauma many years ago and probably had a kind of posterior fracture of the glenoid. And he developed very early osteoarthritis because it's very unusual to see that when the patient is 35 years old. And so it's a consequence for me, it's a post-traumatic arthritis after fracture of the posterior glenoid rim, probably not reduced. And now he has late evolution of this posterior fracture. I agree with Christian that the fact of the acromion, as he described very well, is not very well formed posteriorly, is probably the favorizing factor for posterior instability. So it's a traumatic posterior instability with an evolution with severe osteoarthritis. So I agree with Gilles that there is no other way than to do a shoulder arthroplasty. This patient is very young, and so I would do a preoperative planning with a standard CT scan.
Gilles, may I ask you a question?
Sure.
Do you think that situation, that a patient who develops a B1, then ultimately a B2 glenoid, do you think is exceptional or is maybe not so rare that has started with a trauma?
That's a good question. I'm not sure I know the answer. I would say that we can see some cases with a B1 glenoid without any previous history of trauma. But I would say that probably most of the B1, B2 glenoid have this abnormal acromion as you described. So trauma is probably not necessary or mandatory for me, but abnormal acromion is probably the main cause. But I'm not sure and I have no proof for that. So anyway, I do a preparative planning with a Blueprint, which is a software, 3D preparative planning software, which allow to reformate the CT scan to be parallel, perpendicular to the scapular plane, so that we are sure that the 3D measurements is reproducible and correct. So here you see on the left side of the left part of the screen that this is a standard 2D CT scan reformatted to be perpendicular to the scapular plane, showing 30 degrees retroversion and probably sequela of this posterior fracture. Let me remove that. You see probably sequela of the posterior fracture here. Here it's a coronal view showing a standard 2D CT scan coronal plane reformatted to be parallel to the scapular plane and showing that there is 13 degrees of superior inclination with respect to the transverse axis of the scapula, the line between the trigonum here and the center of the glenoid. This is the transverse axis of the scapula, and you can measure very easily here the transverse axis and the superior inclination. And this is a regular 3D view showing that 97% of the volume of the humeral head is posterior to the scapular plane. So the scapular plane with this software is determined automatically, taking into account all the points of the scapula. The blue line is a glenoid fossa, which again takes into account all the points of the glenoid. And so the measurements done with blueprint are measurements done between two planes and not two lines. So for these, I would say it's post-traumatic arthritis or instability arthropathy. Doesn't change a lot. And I would decide to do reverse because there is 97% of posterior subluxation of the humeral head, and I'm not able to correct that with any kind of anatomic arthroplasty or soft tissue procedure. And so that's the reason why, even though the patient is 35 years old, I would choose to do a reverse. So this is autoplans that are not required here. I will switch about that. I do not need that, so I switch the autoplan. It's another story. So reverse, we are here in reverse, and I would choose to do start with a reverse 2, because when there is a severe retroversion like this, I like to use bio-RSA in order to reconstruct the bone stock with good bone graft from the humeral head. So on the left side, we choose the prosthesis we want to use. So it will be a standard long peg side, 29 millimeter diameter. I like to use a patient-specific bone graft. And regarding the humeral head, it's a man. So I like to choose 42. And I like also to choose eccentric sphere in order to limit the notching. So now on this screen, I make sure that the base plate is flush with the inferior part of the glenoid. So I need to go a little bit more inferior. Here we go. It's probably, yes, it is correct. Then I check that we have no posterior perforation. Here, in order to avoid this posterior perforation, I put few degrees of retroversion like this. So it's 5 degrees retroversion to avoid this perforation. And now I like to lateralize at least between 5 and 7 millimeter in the center of the post. I always lateralize the glenoid between 5 and 7 millimeter in order to avoid the notching. So I start with that. I lateralize 5 millimeter. In this case, this is 5.5, so 5 millimeter, and that is correct. I have no perforation posteriorly. I can see that here the maximum thickness of the graft is 13 millimeter, and the 13 millimeter are probably right here. 13 millimeter, for me, it's acceptable for bio-RSA with asymmetric bone graft, which is exactly 12.5 millimeter. So I like that, and I would choose this as a bone graft for this patient. And here you see the shape of the bone graft I will use during the surgery. I will shape the allograft, the bone graft from the humeral head with rongeur to reproduce exactly the shape. Then I plan for the humerus, so I would use Ascenflex, as I like to use Ascenflex currently. which is only prosthesis, you see that the platform, the metallic platform, is a little bit below the greater tuberosity, which is fine in order to avoid too much lengthening. So here again, it's a different size and type of the stem. This is size 1, and the filling ratio is 58%, so probably size 2 or 3 will be fine. Size 3 is too big. Filling ratio is 78%, so size 2 will be fine here in order to avoid stress shielding at the upper part of the prosthesis, at the upper part of the humerus. So this looks fine. I have 135 degrees net shaft angle. If I like, I can choose more. If I want to have 145, it's possible, but I like to use 135 because clearly Mark Frankle showed that we had better results and less notching with 135 degrees neck shaft angle. So I follow Mark Frankle for that. And then I check the impingement-free range of motion between the humerus and the glenoid. And what I want to check is that during extension here, we have no contact at all between the polyethylene and the pillar, the scapular pillar. And here you see that there is no notching at all. So I am sure that in this case, we should avoid any kind of notching because of this full extension without notching. So I check also that internal rotation is about 90 degrees, just for the patient to be able to reach the back. And the limit of internal rotation is not friction, but abutment. So it's important to check that you have 90 degrees. Here, I'm okay. I have 90 degrees. So I would accept this. I like that. The range of motion is correct. So I would finalize a plan, build a guide, choose 1 point posterior superior right here, 1 point anterior superior, 1 point anterior, 1 point inferior, and then generate the guide. And with this guide, I know exactly where I have to enter the guide pin. Here will be the guide pin, exiting in the centering point. And that would be exactly what I would do by RSA with this guide, patient-specific guide. So I switch back to the screen. What do you want to do, Gilles?
Yes, I have a few questions for you.
Sure.
There is some echo, I think. I don't know if okay. So there's a question from John Erickson who asks if you have tips to avoid problems with the thin side of the graft, because sometimes it's apparently a little bit fragile.
Yes, sure. Here, for example, it seems that we do not need to have graft anteriorly. In order to have graft anteriorly, I will ream 3 mm anterior. I have a depth stop on my reamer. I would ream 3 mm anterior rear to have 3 mm bone graft anteriorly, and in order to avoid a very slim or very thin bone graft.
And so then the bone graft you harvest using a guide also, or
yes?
How do you?
Yes.
Okay.
The guide described by Pascal Boileau for the bio-RSA. It's an asymmetric bone graft with the thickness is 12.5 millimeter in the biggest part and 6 millimeter in the smaller part.
Okay.
So it will be perfect for this case.
The question, Gilles, do you measure the lateral offset that you do with your prosthesis, or is not important for you?
Because here it says 11 millimeters. So
yes. Yes, that is a concern. What we see here, for me, is not really what we want to know, because this is a comparison of the center of rotation before the prosthesis and the position after the prosthesis. So it's not exactly the global lateralization that we have with that. But I fully agree that in this case, I lateralize the glenoid, we said 5 millimeter in the center, and we use only prosthesis, which is also a cause for humeral lateralization. And at the end of the day, I will have probably higher lateralization, global lateralization, than with an inlay prosthesis. So that is, I would accept this lateralization. Also, I'm not sure it's exactly 11 millimeter, but yes, I do lateralize because I want to have glenoid lateralization, and with the only prosthesis, we have some humeral lateralization also.
And so do you try to inset a little bit your humeral stem, or?
No, if I have a problem, I do not hesitate to cut a little bit more. You see, you can lower down if you want to limit your lateralization. By doing that, you avoid excessive lengthening, distance between the acromion and the greater tuberosity. And by lowering it, also, you medialize more the humerus. And in order to avoid excessive lateralization of the humerus, I use this eccentric, look, this is an eccentric platform. If I put the index, the number 12, meaning that the offset of the platform is inferior right here, you lateralize more. If you use the eccentricity with number 6, meaning that the offset of the platform, as you see here on the bottom right, the offset of the platform is lower, that means that you medialize your humerus, therefore you limit the global lateralization.
And so,
Mark would like to show your screen, maybe to share the screen.
Can I just
Let's go,
ask
Mark.
one question for Gilles? Gilles, can you go back to the last slides, I think?
A joint or glenoid or what?
Glenoid.
Glenoid. Here we go.
Well, if you look on the right slides here,
Yes.
you were extremely close, if I am not mistaken, with your peg to the posterior and to the superior border. Any worries about perforation?
Yes. If there is any perforation right here, look, for example, if I change a little bit the version, you see here, I have perforation. And I don't like to have perforation because I am afraid of a fracture of this small part of the posterior glenoid. So what I do in this case, I just put a little bit of retroversion to avoid this posterior perforation. You can also move a little bit anterior your base plate to avoid this. But as far as I do not see a posterior perforation here, that's okay with me.
and so in this case, where you might have a little bit too much of lateralization, you don't want to downsize a little bit your glenosphere?
No, because in my experience, I never observed any neurological problem because of lateralization. I know that humeral lateralization is not the best thing we can do. We suffer the humeral lateralization, and in order to avoid too much humeral lateralization, I just cut, as you saw, a little bit more than the anatomical neck in order to avoid that. But I never observed any problem with excessive lateralization. It may be difficult to reduce sometimes, I agree, but I did not observe any complication related to that in my experience.
Okay, so now we move on to Mark.
Can you guys see my screen?
We could, but we can't anymore.
Okay, how about now?
Yes, perfect.
Okay, so it's interesting that the software we use calculates 92% subluxation and 16% inclination. So a little bit different than Gilles' software. Maybe not noticeable. For me, I don't think it's noticeable because my treatment algorithm would be similar. I would do a reverse.
It's difficult to hear you.
You can't hear me?
It's not a good sound. Do you have a microphone?
Yeah, hold on, we're working on it. Yeah, how about now? How about now?
Better?
Okay, and you can see my screen too?
Yes, we can.
Okay, so I've already done some of the planning. I can just sort of show you my approach. I can remove some of the things here so you can sort of see where we start. So, this is me placing my pin. So I like to put my guide pin in the center of the glenoid. It makes it just easy to do it from a technical standpoint. I don't feel like I need guides or anything of that nature. I can just simply put my pin in the center. So I'm trying to...
May I ask you, what is the center if you have a huge posterior osteophyte?
So I'm trying to show you how I would look at that. So one way is, just as you said, Gilles, you can look at the scapular body. You can look at the scapular body here, and as you go through it, you can see how I can get to the center of the glenoid here. So I can find where the center of the glenoid is, that white line. I can do it in all three planes, or I can use the 3D image as seen here, and I can just sort of rotate around and see that it would come out in the center of the scapula. So that would give me the center point. But for me, it's often I can visualize it. I can measure the top to the bottom and the sides and find what I perceive to be the center. And if I am in the center, I can validate that in terms of where my screw will go. So if I'm going to put my base plate, which is a simple screw device, and I'm going to now put that at maybe ream 2 millimeters so I can get some bone contact. Yeah. So this is what I'd get. I'd get about 67% coverage. If I wanted to use a small graft, I could, just like you showed. Although with this, I probably wouldn't necessarily need that, because with this implant, I'd feel very confident with the fixation that I would achieve by using locking screws like this. So you can rotate that and see these screws just barely perforate.
So here your goal is to correct completely the version?
Yeah, I want to put it at 0, 0, 0, neutral inclination, because what I'd like to achieve is I want to restore the normal relationship of the glenohumeral joint, and I'll show you what that means in a second. So the glenosphere that I would use has 10 millimeters of offset laterally, but it doesn't distalize. It's a little smaller than Gilles in terms of diameter, and so you can see that by doing that, I don't distalize as much. So on the humerus, I would use an inset humerus. I would use it at 135.
Mark, what is the size of your sphere?
32 millimeters.
32?
Yeah.
Okay. So very small.
Yeah, 32, because I don't want to distalize. So when I put this together, this is how it looks, right? So I have it inset, and if you look at the lateralization, I don't want to distalize. So if you look at your reconstruction, Gilles, you would notice that the tuberosity acromial distance is much greater because you distalize. And I can get the same impingement-free arc of motion as you, because I'm lateralized and I have this 135 neck shaft angle, as you mentioned. And because the patient was osteoarthritic, I know that the cuff's intact, and I could begin to get normal tension because I've appropriately lateralized and moved the humerus laterally. And if you were to look at the direction in which the subscap fibers would go, if you were to imagine that, they would look like they're going in a normal position. So this is how I'd approach this patient with this surgery.
Does it change anything if the patient has no more cuff for you? Because is it relevant to retention a cuff that is no longer there, or?
I don't know that, certainly if there's less cuff, I tend to make some adjustments in terms of what I think the soft tissue tension should be. With the intact cuff, you get a pretty good idea, because if you have an intact subscap, you can put the subscap, if you put it back when you're done where you took it off, and then you range the shoulder and you don't have any loss of motion, then to me that gives me an idea that I adequately tension the soft tissues. So I use that primarily to guide me. But if there's no cuff at all, then there's adjustments that I make based upon what I think is appropriate soft tissue tension. And it may be a little bit tighter, but generally it's not that different.
Philippe?
Yes, I have a comment, Mark. You don't think that the distalization in reverse prosthesis is useful for the deltoid? Is not your experience?
Well, I don't know. My belief is that, especially in an osteoarthritic shoulder, the reason that we're talking about a reverse in this particular patient is because the offset of the articular portion of the glenoid being so dysmorphic. And so in my mind, if I can reestablish the normal length tension of the deltoid, then I've idealized this patient, because I've idealized this cuff and I've idealized this deltoid. So I wouldn't distalize a anatomic total shoulder thinking that would be beneficial for the deltoid. So I don't see the applicability in this particular situation.
Peter, you had a comment?
Yes, we have just discussed 30 minutes on how to replace shoulder in a 35-year-old guy. So when you look to this glenoid, I think that you can choose another way. I would do posterior osteotomy, posterior open wedge osteotomy, to lift up the posterior, to correct the posterior version.
Tu peux remettre radio, Gilles?
Ouais.
Let's go, Peter, sorry.
Yeah, okay. So I would go for a more anatomic reconstruction. So I think that the glenoid, even if it looks very bad, I would do from the posterior incision, and I would reconstruct this posterior retroversion using an open wedge osteotomy, using a bone graft from the iliac bone, as proposed by Herbert Resch, using a chase pen. So I can correct this. I can correct here. I can change the pathologic retroversion, and I can do some reconstruction of the glenoid cavity. And then in a second procedure, the goal is to recenter the humeral head. And in the second step, I would go for just a simple hemiarthroplasty to rebalance the shoulder and to get the shoulder back into the normalized glenoid cavity. And I think that maybe this helps him some years ago, 10 years maybe, and then you can proceed with the inverse prosthesis. Maybe it's an alternative, just in case that something goes wrong with this really difficult reconstruction using inverse prosthesis. I would think about the minimum. I would think about the posterior open wedge osteotomy, because you can really reconstruct the version, and even you can reconstruct the posterior bony defect of the posterior Bankert fracture.
Christian, do you want to comment the proposition of Peter, because you have the experience of posterior osteotomy? Do you do a comment, Christian?
Well, we have just very recently published the first 7 or 8 cases of J grafts in clinical orthopedics in patients who are not really arthritic, and it appears that they are somewhat better than the plain posterior osteotomies. We're just reviewing the glenoid osteotomies, which is a much larger series, and there the results are not very good. The opening osteotomy creates increased pressure on the glenoid, and I do not think that this would work. I understand the concept. I think with the experience that we have made with my current fellow, Bettina Hochreiter and Sylvan Baylor and Dominic Meyer, we think we can say that this will not work because of the acromion. This will not work. So I would not do that. I think it's very difficult. I have no proof that it could not work. But what we are essentially doing, I think what Gilles is doing, what I think Mark is doing, what I would be doing is we would also reorient the glenoid surface. However, we think the glenoid surface is so arthritic that it is essentially lost, and we do reorient the glenoid. I would be opposed not to use a graft in case of future revision or so. I would also lateralize so that we have a sufficient bone stock, well oriented in case that we get loosening. But I think it is too late for me. It would be too late for her.
Christian, I agree that maybe this is not the optimal case because he is really arthritic. But in my own series, I have done maybe 12 or 15 cases with an open wedge osteotomy in more habitual posterior dislocators, and they work quite well. So I wouldn't say no.
Question of follow-up, Peter. For us, ours have a very high rate of osteoarthritis if we go a little bit longer. But it is, they get stable. They usually get more stable. But if we go on, then I may show what I want to say, what I think is a really important concept. We are looking at the wrong X-rays.
Gilles, do you have the same experience of osteotomies than Christian? Because I did 2 times and with a failure, and after I convert to reverse.
Completely. I also did many cases of opening wedge osteotomy of the glenoid, and the long-term results at 8 years, 10 years are awful. I did that many times. And you increase, as Christian said, you increase the constraint, the posterior constraint between the glenoid and the humeral head. And in this case, with severe osteoarthritis, the patient will be completely stiff and will not enjoy any improvement, I believe, if you do an opening wedge osteotomy in this case. I agree with Peter that the patient is very young, 35 years old, but it's a very exceptional to see this kind of severe osteoarthritis, post-traumatic arthritis, sequela of posterior glenoid fracture. And whatever I try to do for this kind of patient, he won't be very happy, and he's 35, so the goal is really to give him a good range of motion, free of pain, and no more posterior static instability.
Yeah.
There are many questions in the chat regarding the limit for you between anatomical and reverse prosthesis. Do you think that the rate of retroversion, there is a cutoff when you decide to do reverse? Gilles, for example?
The cutoff for retroversion, you mean?
Yes.
No, I do not really have cutoff for retroversion. I believe that a good indication for reverse is when there is nothing else to do. I mean, I have no other satisfactory option. And I know that if I do anatomic prosthesis in this case with augmented glenoid, for example, it will sublux again posteriorly, and at the end of the day I will have a very, very bad glenoid without bony reconstruction, without bone graft, and it will be worse within 5 to 10 years. So for that reason, I know that it seems to be crazy to do a reverse at 35 years old, but it's also crazy to do a shoulder arthroplasty at 35 years old. So if you decide to do a shoulder arthroplasty, choose the best one you can. And in my mind, in my experience, with this static posterior subluxation, the best prosthesis ever is a reverse.
Okay. Peter, I remember that you published a series of anatomic arthroplasty with rebalance the humeral head and with good result, a short follow-up. No, Peter?
Yes. It's a follow-up of only 2 years. And at that time, the humeral heads were resented, but the same series later, 4 years later, they have been desented mostly. So this the experience of Christian also. The recentering is a preset. It's that's a multifactorial problem, and depends on the humeral version, depends on the glenoid version, and on different aspects like Christian has shown. So I think we don't understand not fully yet the problem of the of the posterior subluxation.
So if we summarize, if you had to operate on this patient tomorrow, you would do a posterior osteotomy and bone graft.
You mean on the guy from on the 35 years old guy?
This patient, yes.
No, after this discussion, I also go for inverse prosthesis, of course. But I just want to ask my colleagues if what they are thinking about, because I have done as Gilles and Christian, and maybe it's important to say that they have bad experience, and so I have to agree, of course.
Okay. Christian, you would like to show us, to share your screen, maybe? Christian?
Well, do you see the slide
Yes,
here?
it's perfect, yes.
Yes, it's perfect, Christian.
So what I wanted to say is that here you see a slide that Gilles already showed at a certain height, and the problem is that we really do not know at what level that is. And I can only and exclusively plan if I simultaneously have the 3 cuts which show me where I am. If I do not know where what that level is, and I do not know whether it is here or up here or down here, I cannot really plan. I must know at which level that I am, and you will see that the retroversion of the glenoid changes a little bit according to whether you are very superior or we are very inferior. And to accommodate for that, you have to have these images. And if I go back, you see that there I would be a little high in the middle, and I want to be lower. I can measure with my measuring device exactly where the center of where I want to enter the glenoid. So I go a tiny little bit lower, and then I have the measurements that I need where I want to introduce my glenoid. Here I show you in the middle what we call Maurer angle in the CT, and we look at one thing a little bit differently than I think Gilles does. Here we use the Maurer angle. That's the deepest part of the supraspinatus fossa. And the supraspinatus fossa is not exactly parallel to the scapular blade. And probably the key issue of traction is the supraspinatus, which is not perpendicular to the glenoid. It is a little bit different. So it goes, if you look from here, the supraspinatus, if I would go up, is in this direction. It is not exactly in this direction. That's why I sort of consider that. If you now imagine that the supraspinatus is pulling in this direction on a slope oriented posteriorly, it pulls posterior. Now, to go here, we had 66 degrees in the Maurer line. We want at least 75, but maybe you want 90. Pascal Bolo wants 90. If he wants 90, he has to correct 25 here. And I would do that by mostly using a bone graft, a wedged bone graft. And I decide, I do not know what is absolutely right. I know that below 75 is certainly bad. I usually go to 80, 85. And then if I have 80 to 85, I draw that in with a line and I see exactly the size of the graft. The same thing is here. Here I will go to 90 because that's the normal value that we have measured. And I measure the posterior size of the wedge. Here we had, I have measured 98, or that's 90 degrees, but the retro here was pretty much 30 degrees. So I use all these images simultaneously. I cannot plan if I only have horizontal cuts. And if you look here, that's, if I may, I show you quickly another case with the same problem. That's the typical Maurer angle. You want not to correct a lot here. Then you see where you want to have the insertion point. And then you see that you may be too high or too low. And you have here, you have the correction angle on one level and you have it on another level. And then you see here what you have to correct. You can decide what you correct. Here I would correct with the wedge that you're seeing there. That's actually what I did. And I see at what level I am. If you look at this level here now, I want to go a little bit lower. I have just gone down maybe 2 millimeters on the screen, and that changes the other screen here. I'm not exactly at the same entry point that I was before. But when I'm at the right height and when I'm at the right anteroposterior direction, I know where my entry point is, and I can measure that from here to here, and I can measure that from here to here, and know the direction. I see, for instance, I know exactly what the direction of my entry point has to be. So I have always said that CT is a three-dimensional investigation. It's not a two-dimensional investigation. However, it is crystal clear that if you only use one plane, then it is two-dimensional. But I mean, what Gilles has shown and what Mark has shown is an extremely elegant way of doing that in an automated fashion. But we just do that by hand, believing that orthopedics is an intellectual discipline and not a manual discipline. Now, here you see something very important. You see a completely horizontal acromion. You know, if you have a completely horizontal acromion with the head rising relatively high, and this head, if this head flexes, if you elevate your arm, the head can go out the back without any posterior restraint. And I don't know whether I really want to bother you, but here there is an additional information. If you have put your glenoid base plate here, you can, for instance, say, where do you want to go with your screw? Your screw at 1.5 centimeters away from the base plate has to be posterior. There's only bone, it's only posterior. Anterior, there is no bone. So you can know that from the preoperative CT scan and can plan accordingly. Same thing here, the three-dimensional cuts that you always see at what exact level you are. And you must know on the AP and the axial and the frontal view where you are. If you don't mind, I would, Philippe, do you quickly want to see the thing about the acromion, or do we go on?
Okay, let's go on.
Okay, here I show you a case who has a B1 glenoid. The patient, if we look at a three-dimensional representation of his glenoid, we have the pathological case is the blue one, and the statistical shape model, the normal one, is the green. And that the glenoid that is violet is the corrected one. Now, if we look at that from posteriorly, we see that the glenoid here, that's a posterior instability, B1, is tilted inferiorly and has to match the statistical shape model, has to be reoriented. And how do we do that? The first step is that we three-dimensionally plan and with cutting guides plan the osteotomy of the glenoid, then do an osteotomy of the acromion back here of the scapular spine, and translate and rotate the acromion so that it becomes a normal acromion. Here you see this case post-operatively, and if you look at the preoperative acromion here and the post-operative acromion here, you see how different the orientation is. And this is the post-operative CT scan. In this case, you can then control that in 3D. The blue is the one that you wanted, and the violet is the one that you have obtained. And it's quite interesting that, I mean, that's very early here. The patient is healing at 3 months only, but that's what it looks like. And we know from experimental data that the orientation of the acromion is at least as important as the version of the glenoid. It's not all. The version of the glenoid is also a factor, but the acromion is crucial. And if we look here at preoperatively and postoperatively, the head cannot move out very easily. In that situation, compared to that situation, simple elevation of the arm to 35 degrees leads to an increase of posterior translation of about 3.5 to 4 millimeters. So we try to avoid that, and that's very early. I agree, you know, that's very early, and we will have to look for a long time. But at this point in time, with correcting glenoid and acromion, I think we can recenter. And if we do not have a posterior acromion that protects posterior escape, I think the anatomical prostheses will not work. They will have tilting moments and they will loosen, as Gilles has shown. But if we decide, can we do with the retroversion? The question was, what is the cutoff for the retroversion that you can do an anatomical? I think the question is incomplete. What is the cutoff of as well the retroversion and the orientation of the acromion? Okay, that's what I wanted to say to the combination of the two things. I really believe that in prosthetics, in a future time, the orientation, at least for the anatomical prosthesis, the orientation of the acromion will become a crucially important factor.
Christian, it's very, very, very interesting. Do you think that it's a procedure that you can propose in posterior instability?
Yes. Yes, it's actually quite interesting that the dynamic posterior recurrent subluxations have often an almost even higher acromion than the B1s. So they are very similar, and that's why I asked Gilles. You know, I think that sometimes it is so that people have a predisposition for static posterior subluxation. They just have that predisposition and are lucky. They never have an injury. But what we have seen when we reviewed our recurrent posterior subluxers that we operated on, when we retrospectively reviewed them, there was a fair number who had static posterior subluxation before the surgery. And these are very often those that fail. If they have static posterior subluxation preoperatively, they have a very high and flat acromion.
Christian, I have a clinical question. In these cases, as you have described, when you investigate them, when you examine these patients, do you see some scapular movement? Do you see some...
No, they have no scapular dyskinesia. No,
they don't have?
They don't have a scapular dyskinesia, no. But we've been interested in that now for 2 or 3 years, and that was what I showed you was the first case of a we call that a score osteotomy, correction of the orientation of the acromion and of the glenoid of the scapula. But we have really a lot of experimental evidence to prove that the acromion, a normal acromion, is a substantial posterior restraint, a substantial bony restraint. There is no question for that in my mind. And if you start, it is very interesting. I see tons of patients referred to me with x-rays and they never have a near view. And nobody has ever looked at the acromion. They come with indications to glenoid. And I really, the fact that we are correcting the glenoid for 10, 15 years and we are not successful, that means something is wrong. We are somehow not on the right track.
I really fully agree with Christian. I really believe that he discovered something that we saw that for many, many years without understanding. And I really believe that what he described about acromion dysplasia, posterior one, is probably the cause of these static posterior instabilities that we do not understand. And this paper, this study, this research from Christian is really, really important because nobody looked at this in the past, and that is fundamental. I agree.
So your indication would be the same as periacetabular osteotomies for hip surgeons, right?
Well, it is the periacetabular osteotomy is also a kind of an extra-articular operation. I think there are some parallels to it. But how I proceed. We have an observation. We verify whether this observation is consistent. Then we take it to the lab. Everything that we have done in the lab so far, is very, very convincing. We have received P1 cases from Gilles. We have received P1 cases from Ianotti. We have our own cases, and they're all the same. And it is interesting that the statistical shape model, which I showed you as the normal variant, there are 30, we have taken 30 healthy shoulders, non-arthritic, non-unstable, and so forth. And they are relatively similar. Their orientation is relatively similar. And the difference between static posterior subluxation and or dynamic posterior subluxation and the normal is dramatic. I mean, it's not a little bit different. It's very different, And actually, I can tell you, for you all who do arthroscopy, we actually started to realize that because if you do a posterior bankard, that is usually extremely easy because you get in with the arthroscope very, very, very high. And in some cuffs, if you go underneath the acromion, you can hardly see the insertion of the supraspinatus. And actually, that was the start, that we said, why in the hell can we see so well and can repair so well? And the fact was that the acromion is very high.
Yes. And I think the message, Christian, is to come back on your whole patient and to analyze preoperatively all the X-rays. And we have to look for the same deformity. If everyone go back 2 or 3 years ago and we analyze our cases of posterior subluxation, maybe we will do a very nice study about the shape of the acromion. What do you think, Gilles?
I agree. I did it when Christian told me that 2 or 3 years ago, maybe now. I checked that, I did it, and I can tell you that it's crucial. I mean, I saw that for many years, and I did not realize that it was possible to measure the slope of the acromion, the overhanging of the acromion posteriorly, and so on. And that is evident. Evident is,
obvious.
Obvious, yes. If you look at this on the lami view or scapular view or near view, whatever, or impingement view, outlet view, you will see that, definitely.
And did you find anything relevant for anterior instability or?
No, we didn't either. Actually, the fact is that with respect to normals, the shoulders with anterior instability are not significantly different in terms of acromial shape. But for posterior, yes, and the really interesting thing is that it's the same deformity for static and for dynamic. Huh? It's actually the same, and that's why I think it is possible that, you know, these things, it's like a dysplastic hip. You know, it's a predisposition, and if you are somebody who always flexes your hip to 100 degrees and you have a little impingement, you will ruin it. If you have, and that was very interesting what Gilles said, you know, it is very well possible that this patient had a posterior subluxation dislocation, and then they stay out. They stay statically subluxated, whereas those who do have a normal acromion, they are subluxated and they're back into normal.
So, Christian, what is the influence of laxity, of hyperlaxity? Is this now an overestimated finding?
Yes, I believe so, because, you know, hyperlaxity is very, very often bilateral. And you have individuals who have hyperlaxity and normal shape of the acromion and the glenoid, and they may be even able to voluntarily subluxate, but they do not develop static posterior subluxation. They do not develop that. Hyperlax persons do not, unless they are operated on, maybe, but if they're not operated on, they do not develop posterior static subluxation, or at least I have not seen that.
Thank you, Christian and Gilles, and it's very, very interesting, and we can continue all the evening on this subject, but we have to stop. I think that the attendees, 162, are very pleasant, and I think that we have to do another session regarding the preoperative plan, because I think that Gilles show us a very elegant preoperative plan, and Mark also. We have with GD another software to do a preoperative plan. I think that a new session, if you agree, and I will send definitively completely CT scan, Christian, in free, the same level in pre-plan. I promise you. And I think that everyone will be interested. So next time it will be the last of before the summer, and we will discuss about the recurrent rotator cuff tear. And we invite 4 guys to discuss with Gilles and me. And thanks again, Peter, Christian, Gilles, to spend time to explain. Mark, Frankle, Christian is always very interesting. And I think that we do again this session. Thank you a lot. Thank you, Gilles.
Thank you.
Thank you. Thank you.
Have a good evening. Bye.
Thank
Bye-bye.
you so much. Bye-bye.
Good evening, everyone.